Welcome to today's clinical case mystery for FNP board review. As we go through the patient's story, see if you can identify the diagnosis before the final reveal. Our patient is a 28-year-old male, presenting with a rash on the palms of his hands and the soles of his feet for about 1 week. He has no major medical history and no prior sexually transmitted diseases. He is sexually active with men and women and has had unprotected sex with 2 partners in the last 3 months. He endorses fatigue and fever. He denies headaches, vision changes, dysuria, penile discharge, or current genital lesions. Laboratory testing reveals a reactive RPR with a titer of 1 in 64. Confirmatory treponemal testing with FTA-ABS or TPPA is positive and HIV screening is negative. Before deciding on a diagnosis, let's consider the differential for a palms and soles rash. This distribution is uncommon and narrows our list dramatically. The differential includes secondary syphilis, Rocky Mountain spotted fever, hand, foot, and mouth disease, erythema multiforme, Kawasaki, meningococcemia, and severe drug reactions. Now think about which of these fits best with this presentation. A healed painless sore, systemic symptoms, lymphadenopathy, and positive serology. The VDRL test is another test used primarily for syphilis screening, although the RPR is more commonly used in outpatient settings. Its most important role is in the diagnosis of neurosyphilis, as VDRL is the only validated test for use on cerebrospinal fluid. A positive CSF VDRL confirms neurosyphilis, although a negative test does not rule it out due to its lower sensitivity. Like the RPR, VDRL titers are also used to monitor treatment response, with an expected 4-fold decrease in titers at follow-up intervals, typically at 6 and 12 months after therapy. Based on his history, a healed painless genital lesion followed by palms and soles rash and systemic symptoms, what diagnosis fits best? Think about the stages of a certain infection. The diagnosis is syphilis. Syphilis is a sexually transmitted infection caused by the spirochete Treponema pallidum, known for its progressive, stage-based presentation. If untreated, it moves from a painless canker to systemic rash and eventually to severe neurologic and cardiovascular complications, making early recognition essential for every FNP. In primary syphilis, a single painless canker at the site of exposure is seen. It is firm, round, and self-resolving, exactly what he had 6 weeks ago. On the other hand, in tertiary syphilis, this occurs years later. In an untreated infection, it can cause GUMAs, cardiovascular complications such as aortitis, and neurosyphilis with gait problems or personality changes. When you connect all the clues of this case, the healed canker, the systemic palms and soles rash, systemic symptoms, lymphadenopathy, and positive serology, this presentation is classic for secondary syphilis. The recommended treatment is a single intramuscular dose of benzathine penicillin G, 2.4 million units. All sexual partners from the past 90 days need empiric treatment. Before giving penicillin, counsel the patient about the Jarisch-Herxheimer reaction. This may occur 6 to 12 hours after treatment and causes fever chills, myalgias, and temporary worsening of the rash. It is not a penicillin allergy. It is caused by a rapid spirochete lysis and resolves within 24 hours with NSAIDs and supportive care. Follow-up includes repeating the RPR titers at 6 and 12 months. A successful response is a 4-fold drop in titers, such as 1 in 64 decreasing to 1 in 16. Okay, let's review some key points for the boards. Remember, a painless canker is primary syphilis. Once you have a rash on the palms and soles, this is secondary syphilis. RPR is used for screening and for confirmation we use the FTA-ABS or the TPPA tests. Benzathine penicillin G is first-line treatment, and the Jarisch-Herxheimer reaction is not an allergy.